Welcome, everybody. Thank you for joining us. This is the inaugural webinar from the Centre for Global Epilepsy, part of a series of webinars which are going to be held at least once per term called Connections and Conversations. We have some wonderful speakers and very close friends joining us for this first event. So Sloan, Action and Mary, and we will pass to them in just one moment. This is part of the initiatives coming from the Centre for Global Epilepsy. As mentioned, the titling of this webinar series and part of the program is on connections and conversations, and that's very much what the idea is. The idea is to have interesting conversations seeded by interesting people, but also to develop and curate new connections between the attendees and also between the attendees and the speakers. Looking at the people who are here, there are some old friends, some new friends, and some people yet to be friends, but it's all part of something that we're going to do together. So the Centre for Global Epilepsy itself was established in October 2024, launched in January 2025. So it's a young initiative, and the idea of the centre is to act as a catalyst and an umbrella organisation to try and really improve care for people living with epilepsy in resource limited settings, whether that happens to be in low to middle income countries or marginalized communities within very high income settings. And you can see there that the mission of the centre is to empower global epilepsy research and care together, build a global network, lead capacity building, develop culturally contextualized tools and techniques, and work alongside people affected by epilepsy in their communities. And we strongly align to the idea that by fostering an ecosystem through which research, clinical expertise, and advocacy can intersect, we can really create lasting, durable change in global epilepsy care. There's no point in doing initiatives and then actually once the initiative stops, everything goes back to how it was. So there has to be real impact that's actionable, measurable, and that sustains. And we have to believe that we can do it. So Arsenal won the Premier League for the first time in 22 years yesterday. They're in the Champions League final for only the second time in 140 years. So it can all happen. So we have to believe that it can happen, even though even my own faith in Arsenal wavered on occasion this season. So if you would like to be part of this endeavour, and we very much hope you do wish to be part of it, please scan this QR code. You know, it's impossible now to have a presentation without a QR code. So this is the QR code here. This is to join the Global Epilepsy Researcher Directory. This will also be shown at the end of the presentation. You can get the QR code or link directly from the website. And this is to be part of the Researcher Directory, which again is an opportunity to showcase the work that you're doing. And it doesn't have to be in research, it could be in advocacy, it could be in community engagement, many fields, all are welcome, but also to enable you to be part of this network, see who else is part of the network, and then develop new ideas with them also. And with that, I will then pass over to Professor Sloan Mahone, very long-standing friend who really introduced me to global health many years ago, and she is going to kindly chair and guide us through the rest of this Conversations and Connections webinar. Thank you, Sloan.
Thank you. Hi, everybody. I'm Sloan Mahone, and I'm a historian of medicine based at Oxford University. And specifically, my background is working in the history of psychiatry, mostly in Africa and during colonial occupations, and the history of photography. But some time ago, I started to fulfill my kind of long-standing interests in the history of epilepsy and representations of epilepsy, looking at epilepsy through the humanities, but also engaging with clinical medicine and neurology and clinical neurosciences here in Oxford. So I'm going to give a brief talk. All of our talks are pretty brief, about 8 to 10 minutes. And we'll have 3 talks, myself and, as Arjun said, good friends and longstanding colleagues, Action, Amos, and Mary Bitta will follow. And then we'll open it up for conversation and questions. And Quiva will help us moderate the questions through the chat. mechanism. So feel free to ask questions at any point, and Quiva will sort of field that. So next slide, please. So my title referred to stigma, and I am going to talk about stigma, but I'm also going to talk a little bit about the bigger picture. So where we sort of began, and a crucial part of the Center for Global Epilepsy, is the kind of multidisciplinary nature of the work that we do. And part of that has been foundational engagements with what we call embedding oral history into global epilepsy, and ultimately into mind-brain health. And so what we mean by this is thinking about ways that we can privilege people's life stories and life histories through oral history as perhaps a more nuanced way of engaging with people's stories beyond survey approaches or some other types of qualitative research approaches, which might be a little too structured to capture all the nuances of people's lives, but also capturing how they would like to tell their story. So individuals telling their own story adds an element of expertise that we don't necessarily capture if we are engaging only with structured interviews or kind of more standardized ways of collecting information. Next slide, please. So from the humanities and also social sciences, we might think about ways of writing and ways of capturing stories, as I mentioned. So memoirs, storytelling, increasingly digital storytelling, engagement with video. So not just text and audio, but ways that we might, again, capture people's kind of lived histories. Is becoming increasingly important in research, but it's something we identified a while ago as neurology and history started to talk to each other a little bit. Now, historians would say that collecting these stories are important in their own right as historical documents, as historical evidence. But we also want to think about ways that we can apply historical research and storytelling into kind of clinical settings. What a lot of these stories and histories and memoirs capture often are feelings of marginalization that comes with sometimes living with a chronic illness or condition, particularly when that condition is as heavily stigmatized as we know epilepsy to be. So I want to talk a little bit about spaces where some of these stories also might take place. Next slide, please. So where does stigma happen is a question we might just kind of keep in our heads as we kind of go through these histories. So stigma, many people I think have probably an idea of what stigma means, what it is. We can think of it as a negative bias, a sense of disapproval that might be attached to a person or a condition or a trait. So these kind of negative stereotypes and beliefs lead to an outcome, and the outcome might be further marginalization, it might be discrimination. Questions that we might think about is how stigma is manifested through language. This example here on the slide, this is language built into the environment, literally in the built environment. These are not uncommon kind of historical relics that we can find all over London, for instance. Another example of Toronto, where language like incurable would be attached to a type of person or a type of condition. We also might think about language in terms of historically how we referred to individuals, we referred to people as a condition. An example of that would be a person who has leprosy or Hansen's disease historically would have been called a leper. And there's an impact to this. There's an impact across all kinds of sectors, whether that's in medicine or in family relations or in communities. There's an impact and also a self kind of felt impact of naming and labeling naming somebody or labeling somebody as a condition, not as, using their name, for instance. So next slide, please. So we know stigma and health-related stigma is what we're kind of interested in here. And there's a few points here, I think, just to point out that we can maybe talk about in our discussion section. But health-related stigma, characterized by exclusion, rejection, blame, devaluation, and all the other kinds of impacts of stigma, resulting specifically related to a condition, an illness, or a disability. I have another kind of little section here on comorbidities, intersectionality, and thinking about internalized or self-stigma, because stigma is very complex. Stigma itself as a term is quite an umbrella term. So it doesn't really mean anything unless you kind of attach it to a social context. But the important thing to remember is that the context is not simple in and of itself. It's not one form of stigma. Stigma will attach itself to many different aspects of an individual's life. And what our oral history program is showing us, that we can think about stigma and the kind of lived experience over the whole course of a life, so that people, when kind of referring to their own kind of memories and recollections, whether it's childhood or thinking about getting married, any of these kinds of life course events, stigma can have its own kind of very intractable impact. Next slide, please. One interest that has come out of the work that we've done at the CGE and is ongoing with some kind of side projects in Cape Town is stigma within healthcare settings. And I think this is quite important and interesting to me, because again, when we think about stigma, we almost have stereotypes of what stigma is. And in some of the settings we work in, throughout Africa, for instance, there might be assumptions that stigma happens in rural areas, in villages, maybe within families, sometimes within schools, particularly in rural areas, but not exclusively. But we also have to think about the stigma that can occur at Oxford University, in a main teaching hospital, in capital cities, in large institutions. Stigma is something that happens everywhere. And so what we have to be engaged with is kind of meeting it where it is and understanding that context. So one of the examples I give on the slide is stigma within healthcare settings can kind of rear its head in a whole range of ways. For instance, pessimism about managing a condition or its curability. Think back to the signs on buildings, hospital for incurables. That can affect approaches to care. We know historically, for instance, that doctors really shifted in their attitudes towards patients and their treatment towards patients when they thought a condition was curable or not. So if something is thought to be incurable or intractable, sometimes historically we've seen that people are treated much worse, and they very much become the kind of personification of an illness rather than being seen as the individual that they are. Again, it's important to see that people may be subject to more than one stigmatized condition. There may be comorbidities with mental health conditions or other sorts of conditions. So that just adds to the complexity of the experience of stigma. The built environment, again, the signage on a hospital might have an incredible impact on how somebody feels when they're entering a healthcare setting. And so does that create extra barriers to accessing care? And that's a question we have to ask. And thinking about stigma reduction, with these kind of points in mind, we have to think about all levels of staffing, from, if we're in a healthcare setting, from the very kind of entrance to a clinic or a hospital or a healthcare setting, all levels of staffing have to be educated, have to have some awareness to understand that the healthcare setting itself is not kind of free from bias. Next slide, please. So this is from WHO materials, and really I'm interested in the kind of the second, third, fourth, and fifth points here. Some of this have come up in the oral histories that we've collected across our various sites. And one thing that comes up all the time is the potential of traditional healers or community level healthcare practitioners engaging with either education or helping with the kind of treatment and diagnostic pathways for epilepsy. So meeting people kind of where they are. It's not helpful to talk about needing to see a neurologist if you have two in the country. So there has to be other ways where we're listening to people to understand how they do access care and what they think of as a barrier to accessing care. Otherwise, if you try to kind of implement a one-size-fits-all engagement, that's unlikely to be helpful. Again, thinking about language, and this can extend to media depictions as well. And I think many of us have kind of seen and heard, whether it's in newspapers, in kind of publications where we think they should know better. This could be even medical texts, where language can be quite hurtful or derogatory, whether or not there's a direct intent for that language to harm. We think about ways that when we learn from oral histories, how we might better implement programs of education. And that really starts with incorporating people's lived experience from the very beginning, from the kind of inception of projects. And that's something that we've tried to do. And basically providing families, communities, kind of the broader society with more information about epilepsy, thinking about the myths that exist, some of which are very, very long-standing. And we see this in kind of historical practice that there's certainly not a linear progression towards lack of understanding to full understanding. Sometimes problems are cyclical, and the same kinds of biases come out again and again, but with different types of language. And so that's something we have to always be on the lookout for. Next slide, please. So one of the things that really is reflected, I think, in the Center for Global Epilepsy is the multidisciplinary nature. And Arjun mentioned the research database, and it's really important that we have representation from all sorts of disciplines and areas of expertise and experience. And I've listed some here that I think it's probably not surprising where some of these disciplines can help with our understandings of epilepsy and epilepsy-related stigma. Medical anthropologists, of course, epidemiologists. We can learn from numbers, including health economics, implementation science, allied mental health fields as well. Next slide, please. But I'd like us also to think about the humanities. So part of my role in the Center for Global Epilepsy is in helping us engage with the humanities in a broader sense. So while we might think of psychiatry or anthropology or epidemiology or global health engaging with these questions, we need also to think about history. We need to think about music and literature, art, photography, philosophy, architecture, and many more sorts of engagements. So we can not only learn from kind of the experience of the whole of people's lives, but we can also start to celebrate what people's talents are and what people's expressions are about their own lives. So we learn to listen through music, literature, history, and so on. So I think that will conclude thank you. That'll conclude my part of this. And let me now introduce Action Amos, who will be our next speaker. Thanks very much. Action.
Thank you a lot, Sloan, and appreciate your presentation. So my name has already been introduced. I'm Action Amos. I serve as the regional coordinator for the International Bureau of Epilepsy, responsible for all the programming within Africa. And I'm also a research fellow with the University of Edinburgh in the School of Medicine and Veterinary Science, to be specific, in the brain science unit. And I'm also a person with a lived experience. And thank you so much for giving me this opportunity to reflect on epilepsy stigma, which is a challenge that continues to affect millions of people across Africa, as well as beyond. So today I'm going to address how stigma manifests, why it matters as a public health issue, as well as what role each one of us can play to reduce it. But before I move on, I would want to just start with this African proverb that will guide the rest of this presentation. And it says, maybe you have heard it before, it says, a spider's web, though made of tiny threads, can tie up a lion. So this proverb actually reminds us that small things, when woven together over time, they become so powerful. So in the same way, stigma is also often built from many small threads, such as fears, myths, silence, exclusion, misunderstanding, and discrimination at times. So over time, these threads now become so strong enough to isolate people and to deny them any opportunities, dignity, as well as access to care. But what this proverb also tells us is that there is also hope. If stigma can be woven together, I think together we can also be able to untie it. Next slide, please. So as we heard from Sloan, he defined stigma as a typical social process. I don't differ a lot from him. I do agree that it is a social problem, but also it is a public health problem. I'll pause here a bit and ask you to think deeply about this statement. Why would we say stigma is also a public health problem? Oftentimes, stigma is discussed only as an issue of attitudes or discrimination, but in reality, stigma directly affects health outcomes. So, for example, people may avoid to seek treatment because they fear to be seen maybe at a clinic. Families may hide relatives with epilepsy because of shame. Children may drop out of school. Adults may lose employment. And communities also might even rely on harmful misconceptions instead of evidence-based. So then this means that it then contributes to delayed diagnosis. It contributes to interrupted treatment, worsening seizures, poverty if they are not employed, and even social isolation. So from that statement, you can easily see that actually it is a public health problem. But just like that spider web in the proverb, stigma becomes dangerous when these small misconceptions or social issues build up, then contribute to the public health problem. Let's move on to the next slide. So I'm not going to define stigma. I think my colleague Sloan has actually defined the stigma well, but I'm going to define it in a way of two stories. So these stories, one is of a rural girl called Chimwe from Malawi, and the other one of myself, who I am referring to in this as an educated Black male in an urban setting. Chimwe, though now is no longer a girl, she's a woman, but I will start on her being a girl. So she was born in a small rural village within Malawi. Like many children, she loved school, playing with friends, and also had a dream of becoming a teacher. Her parents described her as a bright student, curious, and full of energy. But when Chimwe was around 10 years of age, she experienced her first seizure at school. The classroom became silent. Some children screamed and ran away. Others believed that she was possessed with evil spirits, and teachers were unsure what to do. From that very day, whispers began. So that was the first square of stigma in Chimwe's life. At home, her family became afraid and confused, and different people in the community had also different explanations about what had befell the family. Some, they said it was witchcraft, others believed it was contagious, and her parents spent their time moving from one traditional healer to another, hoping to remove the case. Meanwhile, as she had already started school, she started missing school and started not playing with others, because at school, the children didn't want to associate with her. Either they were told by their parents, don't play with her, don't associate with her, it's contagious, and so forth. That did not end there at in the early years of her life. When she became an adolescent, when friends were socializing, she was excluded because people feared that she might have a seizure. And some community members actually were even saying at that age that she was not going to be married, and her confidence began to disappear. That again was another square in her life, and that was a stigma that was also creeping in. Eventually, she reached a district hospital. She was diagnosed with epilepsy, and medication assisted her to reduce her seizures. But another challenge came up in the rural Malawi, as in many parts of rural Africa. Access to medication is an issue. That again became a challenge because there were a lot of inconsistencies on availability of medication. And at times it would be available, but at times transport for her to go and get the medication was not available. Again, despite the improvement in health, stigma remained. Then potential employees could not even entertain her. She could not be employed. So all her dreams were shattered. And as we talk, yes, she's still not yet married. She's a bit older. But later on, she started participating in some epilepsy group, and now she has started. She has built her confidence back. But this story just reminds us that epilepsy stigma itself cuts across someone's life journey and describes well what stigma is. Now, let me move on now to my own story, and we'll relate later these two stories. So I was born in a middle-income family, and I had the privilege of attending some of the best schools. From the outside or from those that would look from outside, my future was quite stable and promising. But at the age of 17, my life suddenly changed. I experienced my first seizure during a wedding ceremony, a day where family members were supposed to be happy and joyful. It turned into a fear, embarrassment, and confusion among the people. Guests that were at the wedding could not understand what had happened. My parents became confused and also frightened. Just like many families in our communities, at that time, we struggled to understand the condition. This was because to limited awareness and also information surrounding epilepsy. And my family initially sought alternative forms of care until eventually I was diagnosed that I had epilepsy. But the journey was not only medical, it was deeply social as well as emotional, not only to me, but also to the family. Remember, I was 17 years old, and now I could realize and tell what was happening. And stigma followed persistently across different moments. And there were moments where people started even viewing me differently. They questioned my abilities, and how they treated me. They treated me with fear and uncertainty. And my condition affected a lot of opportunities. I had delayed schooling. I could not, I was at a point where I would be in the university. During the university time, my education was delayed. When I got employed, some of my employers had assumptions on my based on my condition, but not on my abilities. So over time, I then learned how to live with all these type of assumptions and stigmas that were disabling me. And I realized that it was not the condition, but it was the environment that was actually disabling me. One of the most personal moments that I would want to share, because of time, I cannot go on further with the story, was during my own wedding in 1999. I had a seizure during that period. And in the middle of a day that was supposed to be the happiest of my life, I had a seizure, and the wedding, 3/4 away of the wedding, it had to be stopped. My wife, this was my wife, the wife that I had just acquired then, I would say, actually was witnessing this for the second time. First, it was when we went to a village to bury a relative. She was there and she witnessed. And that also began a journey of being a guardian to a husband with epilepsy. So you can imagine how the community would view. And some of the people that were at our wedding were the same people that were on that earlier wedding where I had seizures. But over the years, I regained my confidence, my leadership skills came. And as we speak now, I became the founder of the National Epilepsy Association in Malawi. I joined with other advocates within Africa. I became the vice president of International Bureau of Epilepsy, and currently I'm the regional coordinator of programs in Africa. So my leadership, though, now is rooted in my lived experience. But what I wanted to share with you is how stigma can be defined from the stories, and showing that across one's life, stigma can prevail. Now, let's move on to the next slide. As I've talked about, stigma happens at all levels. I will not dwell on this because the story have already told us. These are some of the levels where stigma exists, and it includes policy and law, and also even in institutions. We also experience stigma. Let's move on to the next slide. It is okay. It is important for us, to understand how that web of stigma that we talked about in our proverb, or how the knot itself. Just ignore the spelling of the knot that is there. It's not the correct knot that I was referring to. So stigma, it is reinforced by different threads that tighten this knot. And these are such as fear of seizures, lack of knowledge, cultural beliefs, spiritual misconception. And many people fear what they don't understand. So because of cultural beliefs, they think about cases, they think about demonic possessions, witchcraft, and punishment. But that's not these are not the only things that tighten these knots. The next slide is also going to help us to see other drivers of stigma. Next slide. So what are the additional factors that continue to tighten this stigma knot? We have spiritual misconception. My colleague Sloan talked about language and labeling. We have media that reports epilepsy in a way that even worsens the situation. We also have weak police protection. There is also silence and invisibility. So the key message here is that we cannot anti-stigma unless we understand what tightens that note of stigma. So it is important that we understand that and not work with assumptions. Next slide, please, where we'll talk about now how do we untie that stigma knot. So we do so through education and awareness. That's quite important so that we replace the myths and with evidence-based knowledge. We also do storytelling and visibility, allowing people with lived experience to share their stories and also humanize epilepsy. Police and advocates, that strengthens the rights of those that are affected, and also accountability, especially where we have issues to do, say, anti-seizure medication shortages, no budgets, and so forth. Then also community engagement, so working with communities so that we come up with solutions together than imposing solutions on them. So this is how we can untie the stigma. But who is then involved in untying the stigma knots? Let's move on to the next slide. So here I classified this into 3 groups. So we have right holders. These are the most affected by the condition. Persons with lived experience themselves, the guardians, they are the right holders. They also need to be part of this untying. Policymakers, then we have get bearers such as chiefs, traditional and faith healers, healthcare workers, and schools. Then we also have supporters. We have researchers, we have funders, we have civil society. And among the key supporters, funding is quite important, that we need to have funding to ensure that all other things are put in place. So collect action unties collective stigma. Let's move on to the next slide. So a final reflection from all that we have discussed here is that the greatest barrier when we are talking about stigma is not the epilepsy itself. It is the stigma surrounding it. It is the environment. But the good story is that if stigma is learned, then also inclusion can also be learned. If stigma can be tied, then together, all of us, we can also untie it. I want to thank you so much for your attention and engagement in this presentation. Thank you so much.
Thank you very much, Action. Now we'll ask Mary Bitta. The next slide. Yeah, Mary Bitta will join us, and I'll ask her also to introduce herself. We may run over just 5 minutes, but we would like to get a few questions in if possible. So if you do have questions, go ahead and put them in the chat, and we'll get to them right after Mary's discussion. Thank you.
Thank you very much, Sloan, and thanks everyone for joining. So my name is Mary Bitta. I am a postdoctoral fellow in global mental health with a specific interest in stigma in mental and brain health, and I'm also a nurse by background training. And I always ask myself this question when I think about stigma, and I always ask if a decision maker was to ask me or us here in this meeting today, where they would invest their very limited resources in order to meaningfully reduce stigma against people with epilepsy, what would we say? And I just want us to think about that question throughout this presentation. Next slide, please. I hope that at the end of my talk, we just remember this take-home message, and I just begin with my conclusion up front by saying that we know that epilepsy is death and disability from epilepsy is preventable, and I want to pose it to us that it is not the science that stands in the way. It is in fact structural stigma, because we have the knowledge, we have effective treatments, but what I think is lacking is the political will and the policy architecture that can help us deliver care to the people that need it the most. And that is what I hope I will convince you with my presentation today. Next slide, please. I'll be sharing specific data or statistics from Kilifi, which is an area in rural coastal Kenya where I live and work. But the figures that I'm presenting here may not be new to some of you. We know that the numbers are high. 80% of people with epilepsy live in low resource settings, and they are concentrated in places where the health systems are very, very weak. We know the large treatment gap, which is the proportion of people with epilepsy who are not receiving evidence-based or even adequate care. And in some rural remote areas of sub-Saharan Africa, the gap is even as large as 90%, which roughly means that maybe just 1 in 10 people with epilepsy are receiving any care at all. Now, in Kilifi, where I live, the burden is in fact higher than in many places in the world. For example, studies have shown that the burden is about 31, the burden of lifetime active convulsive epilepsy is about 31.7 per 1,000 persons. And if you compare mortality of people with epilepsy compared to people without epilepsy, it's about 6.3 versus 2.8. And I think the gap is not because we don't have effective treatment, because epilepsy is one of the most treatable neurological conditions that we know. But I think the gap is because of stigma, and specifically stigma that is perpetrated by the group that Action has categorized as the duty bearers. That is, policymakers and legislators who, continue to exist in a system that is not serving people with epilepsy, policy failures, and I hope that I will demonstrate that as I continue. Next slide, please. So far, my colleagues have talked about stigma, and Sloan has aptly defined what stigma is. But in many cases, when we think about stigma in epilepsy, we often focus on public stigma. That is stigma that is perpetrated by the general population towards people with epilepsy, or self-stigma. That is stigma that is perpetrated by people with epilepsy towards themselves. And this really, really matter very, very deeply. But today, I think it is important that we push this conversation a little bit, just further upstream, and just talk about structural stigma. And by structural stigma, I mean that this is stigma in the way that, for example, our laws and policies are built, the way our institutional cultures are built, and even the way things like our services are designed. And most importantly, the way funding is prioritized for neurological conditions like epilepsy. And this is important because this kind of things, for example, determines who gets access to care, and they determine whose suffering is taken most seriously. And even when you think about neurological conditions in the context of non-communicable diseases, which is where a lot of funding is allocated, quote unquote, for epilepsy, it is this kind of policies that determine which conditions get how much funding, and as a result, who gets left behind and who receives adequate care. And the reason why I have chosen to really talk about structural stigma is that we know that public stigma and self-stigma, they require long-term shifts in attitudes and in behaviors. These are things that take time to change. But when we talk about change in systems, when we talk about change in institutions, these are changes that can have very wide and very durable impact very fast. Allow me to give an example of such a change in my context in Kenya. So for a very long time, we had been using a very outdated legislation for mental health that criminalized suicide, which means that if you are a survivor of attempted suicide, your first port of call would be with the criminal justice system and not with the healthcare system. Yet we know, for example, that people with suicide deal with sometimes severe mental health problems. But then this was changed through legislation. There was an act in Parliament that was fronted by a nominated senator, and it went through the reins. And now suicide is no longer a criminal activity in Kenya, which means that now it can be covered by insurance. Now the first port of call for people, survivors of suicide attempt, is not the criminal justice system, it is health facilities, etc. So just one policy change made a huge difference in how people with these problems could access care. And so that's why I think that for epilepsy, if we think about like policies or services, or even just things like digital infrastructures, we can very rapidly just change the environment in which stigma against people with epilepsy is like produced and reproduced. And maybe I should give very, very specific examples from Kilifi, where I work. So in Kilifi, we do not have a single neurologist, and I think Sloan had already spoken to this point. There are very few neurologists in the world, particularly in low and middle income countries and in Kenya itself. So here in Kilifi, you'll find that people with epilepsy will be managed either by psychiatrists or psychiatric practitioners or by general physicians. And so it's not just like a resource problem. This is just the way the healthcare system is designed, and epilepsy is not top on the priority of neurological disorders. Let me give another example. For example, WHO recommends the use of levetiracetam as an essential medicine, and there's very strong evidence of its efficacy, and it's being used in many parts in the world. But now here in rural Kenya, the drug itself is available in the Kenya's essential list of medicines, and this essentially means that pharmacies in public hospitals are supposed to procure levetiracetam and avail it in their facilities. But the challenge is that it is very, very expensive, and it is inaccessible in many parts of Kenya, particularly in rural settings like here in Kilifi. And let me give you some figures just to put this into perspectives. Let's say that maybe a public hospital has run out of medication, which happens so often, is almost like the norm here, and a patient goes to a pharmacy to buy drugs buy drugs from their prescription. One tablet of phenobarbital is about 5 Kenyan shillings. And then one tablet of carbamazepine and phenytoin is about 10 Kenyan shillings in the pharmacy, which is like, say, let's say about 8 cents in USD money. Something like sodium valproate is around 30 shillings. But when we talk about levetiracetam, it's about 70 shillings. 70 shillings compared to 5 shillings for phenobarbital or 10 shillings for carbamazepine and phenytoin. And that 70 shillings is for the minimum dose, minimum maintenance dose, which means that if you require a higher dose, that can go into something like maybe 140 Kenyan shillings per day. And remember, there are families in these parts of the world which survive on less than $1 per day. So that means it gets to a point where people living with epilepsy and their families have to choose between things like their basic provision, which is food, access to shelter, and access to things like basic education, versus access to anti-epileptic medication. And then another example is, for example, just data, which is a very important component in decision making. Most of the patient records here in Kilifi, they're held on paper. So patients will go and see doctors, they will receive repeat prescriptions, but there are no consistent records on their neurological assessments, and there's no outcome tracking. So that means that we don't even have infrastructure to monitor whether the care that we are providing is working. It just does not exist. And I think for me, this is one of the points that I find very troubling, because it just means that we don't know what is happening to the patients after they leave the clinics. And they say that, what you cannot see, we cannot be able to fix. So these are just some of the structural changes that I want us to reflect on. Next slide, please. Some of my, both Sloan and Amos have talked about this briefly, which is the pathways to care, the pathways through which people seek care. In many settings, in many resource-limited settings, it's very complex. It's not just a simple journey from having a seizure to going to hospital. For example, here in Kilifi, some patients will go directly to a health facility after their first seizures. Some will first go to a traditional healer. They will never reach hospital. But many of them, they will cycle back and forth. They will go between formal healthcare, which is the hospital, and traditional care. And sometimes they'll even do this simultaneously. And then for some of them, they will reach formal care, but they come very, very late, sometimes not at all. And you can imagine this can lead to very severe like neurological outcomes, and in some cases, even death. And I think my colleagues have highlighted some of the reasons why this is a challenge. It is a lack of public knowledge, but it is also a function of a failure of the formal healthcare system to offer these services, to make them affordable, to make them available, and to make them accessible. And not just that, to make these services culturally resonant, something that I think Sloan has already talked about, which I would like to touch on a little bit in my next slide. Next slide, please. And this is usually a very thorny question, especially when it is discussed in formal healthcare systems, like among neurologists or specialist practitioners and even general practitioners, which is that are traditional healers a barrier, or are they a bridge to care for people with epilepsy? And I would tend to think that my answer would be both. We will not at all solve this problem by pretending that traditional healers do not exist, because they do. The reality is that for a lot of people in many resource-limited settings, they're actually the first point of care for most of the families. And studies have been done here in Kilifi to try and understand, why do people prefer traditional healers, for example, to biomedical practitioners? Because they hold community trust, far higher sometimes than the formal healthcare system. Some reasons that people give is that a traditional healer gives me explanations of my condition that make cultural sense, that have cultural meaning. They spend enough time with me. I do not feel rushed. I feel listened to. Things like they accept alternative forms of payment, not just money, not just monetary payment, these kind of things. And you have to understand that in this setting, for example, epilepsy is understood through a spiritual lens, attributed to things like curses, to witchcraft. And you'll find a lot of patients spending a long time, sometimes years, just seeking spiritual care before they eventually reach the biomedical facility. And sometimes at that point, some of them have experienced dozens of uncontrolled seizures with very severe outcomes. So the thing is, we cannot exclude traditional healers from this solution. They are already, in fact, embedded in the system. So the question to us is, how do we work with them, or maybe against them? For me, I think I see like clear opportunities. For example, maybe just training them to recognize signs of seizures and just referring patients promptly to care and helping them understand why prompt referral and early intervention is good for the patient outcomes. And also something that I've mentioned, which is that they offer some kind of psychosocial support to patients that the overstretched clinical systems cannot, the time they spend with patients. I did some work in 2017 to try and understand the mean amount of time that a psychiatric practitioner spends with an epilepsy patient, because they're the ones who see these patients. And it was about only 3 minutes consultation time. I think it was actually 2 minutes. The median was 2 minutes of consultation time. Why? Well, this was because before they had enough human resource. Now it's a bit improved. But at that time, we had one psychiatric nurse seeing about 70 patients, which included patients with psychiatric conditions and patients with epilepsy, on a Friday only, and they had other duties between Monday and Thursday. And so they had to see 70 people between 9 and 4 p.m. So they had to really, really push the system. So they're already overstretched, and we would not demand of them to offer again additional psychosocial support in addition to their responsibility. So maybe that is an opportunity where we can collaborate with traditional healers and just think about this as like partnerships, that can fill in some of the gaps and create reform faster than any top-down approach that we might want to think about. So I would say, regarding traditional healers, maybe we should think about integration, not exclusion. Next slide, please. I just want to emphasize this point about not having good data. Like I have mentioned, in many resource-limited settings, we are still using paper-based records, and this means that this data is not traceable, it's inaccessible, you can't analyze this data. And in settings like this, where a lot of patients are being seen by non-specialists, they come for repeat prescriptions, no structured assessment, we are not collecting high-quality population-level outcome data. And when you go to a policymaker, they'll tell you they cannot see the scale of the problem. And so you cannot put them under pressure to act if you cannot demonstrate the scale of the problem. And I think, when we do not have good quality data, that's a technical failure. And it is not entirely impossible. For example, if I think about a condition like HIV, we have national level tracing of individual patient data. You can know an individual patient, their treatment regimen, their response to treatment, viral load, etc., at individual level throughout the country. If that is possible for infectious diseases like HIV, why not for epilepsy, which is a chronic condition as well? So I think that is something that we can, that policy can intervene and lead to good decision making and outcomes for people with epilepsy. Next slide, please. So I think, so the question is what needs to change? I think I have already emphasized a lot of these points. Let us subsidize the cost of medication. We know highly effective medication like levetiracetam. Let us figure out ways to improve their supply, especially in rural settings where a lot of people with epilepsy live. The second thing would be, of course, I think it is important. Epilepsy is a neurological condition. It does require expertise. So we need to train neurologists and actually deploy them in rural settings as we continue to utilize available resources within the healthcare system to manage people with epilepsy. I think we cannot ignore the fact that this condition requires a specialized expertise. And so I think that training, investing in that training now is important. I think the third thing is just invest in data and just digital health infrastructure, making our records electronic, tracking outcomes at individual level so that we're able to know what the patient trajectories are, and this data is available to policymakers who can then be able to know how to allocate these resources, because we cannot manage something that we cannot measure. And I think fourth, I would pose it to us that I think it is an important discussion to think about how we can integrate traditional healers into the care pathways, have some form of training, accreditation for them, and just partner with them for early recognition and referral, and maybe psychosocial support that is contextually relevant because they're already in the system. I think it's just time for us to formally acknowledge and incorporate them in patient care. My last slide, please. I think I would just like to finish with where I started, where I say that epilepsy is treatable, medication exists, the knowledge exists, and we should not have death and disability associated with epilepsy in many parts of the world, including rural Kenya. And I think science is not the problem. That is not what stands in the way. I think it is structural stigma. And I think every patient with epilepsy deserves high quality care using evidence-based medication and with all the available support that they can get. So maybe I would just like to conclude by saying we should continue to advocate for policymakers, for funders, for global health partners to just make these things possible so that people with epilepsy can live the best quality of their lives possible. Thank you.
Thank you very much, Mary, and Action. We did begin a little bit late, and we really only have a few minutes for questions, but we do have some questions and comments. So why don't we just take 5 minutes or so, and I'm going to combine some, and I'll ask both Mary and Action just to make a brief comment with those questions in mind. And the first is about intersectionality, and specifically how gender or perhaps interventions for women specifically are different, need to be different. And so how does kind of gender play into how we might think about targeted interventions? And then, so if both speakers can think about that for a moment, but then also I'm going to add the comment in question, if epilepsy is treatable, and we really get that from well, both presentations, but also from Mary ending with that. If it's treatable, why do so many communities across Africa specifically still view epilepsy through the lens of superstition and fear? So Action, do you want to just think about both those? Yeah. So intersectionality and women, particularly in interventions, and also superstition and fear, maybe combine them. And just a brief comment, please, as we end.
No, thank you, Sloan, and thank you for the participant for the question. Yes, it is true that there is an intersection of gender and epilepsy, and research also shows that women they do face a double burden of stigma. Why? Because they are women. So stigma manifests itself related to one, marriage or relationships. So when we talk about marriage, we talk about dating, fertility, motherhood. Those are some of the things that are considered. So one can be considered to be an unsuitable wife or unable to have children, whereas men's stigma can be not related to those things. And I want to give you an example of a country called Tanzania, where the country constitution actually has a specific article which says if a woman is experiencing seizures or has seizures, the man is free to unmarry that woman. We're currently putting up a case of challenging that part article in that constitution. So that demonstrates the stigma on women. It does not talk about a man with who can be experience seizures, but it talks about a woman. And this is a country constitution. It's within the law, the existing law currently in one country. So that shows the double burden that's put on women. Then just a comment on the issue to do why in Africa it's still we still have. So one, okay, it's not only in Africa where superstitions still and fear still prevail. We have other continents as well where that still exists. But one thing that I've noted in my working experience is that there is a limited understanding of epilepsy. And because of also secondly, because of traditional and the spiritual belief system that we have, that again helps to tighten that knot of still having stigma around epilepsy. And also lastly, like what Mary commented about lack of healthcare access. So if we don't have access to formal, where do they go? They go to faith healers, they go to traditional healers, and those are the ones that also perpetuate or promotes issues to do with continued beliefs in superstition and fear. Maybe I can stop here.
Okay, thank you. And Mary, would you like to comment on those as well? And we have an additional question. You did talk about traditional healers, and there's some thinking about how can people who are kind of foreign to a community, maybe who don't engage so much with the traditional healers, also help. So thinking about kind of both intersectionality of the condition, but also of the plurality of treatment. And the importance of addressing that, which I think you did very well in your talk. But a final comment from you, Mary, as well, please.
Thank you, Sloan. And I think Action has, exhaustively answered the questions related to women's health and why it's still highly stigmatized. So maybe I'll focus on the third question. I would say two things, which is collaboration, which is exactly what the Center for Global Epilepsy is doing, working with colleagues across board. And the second thing would be cultural humility, bidirectional cultural humility, which is, approaching the issue with the understanding that there is already an existing local ecosystem, an existing understanding. And so just collaborating with the understanding that conventional approaches might not work. For example, the normal format of training that we are used to might not be applicable in this context. Just working with local researchers and perhaps even traditional healers themselves to co-design and co-develop training approaches that might be feasible for them. So I would say I think we're already one step in the right direction through initiatives like this, which is collaboration. Thanks.
Great, thank you very much. We will have to bring this first webinar to a close. Thank you so much, everyone, for coming in and joining us. If you have any final comments for the chat, we will read them. So please add comments if you wish to. Otherwise, we must thank Action Amos and Mary Bitta. Eva, also thank you for logistical help. And Arjun, do you want to say a final word?
Thank you so much, Sloan. I would just echo what you've just mentioned. I think that was terrific. It was expected to be terrific, and it certainly delivered. So thank you so much, Sloan, Action, and Mary for the really valuable contributions. Thank you to Quiver for coordinating and organising all of this. Thank you to you as the participants for being part of this endeavour, and do sign up to be part of the CG directory, which Mary kindly highlighted, which is exactly on brand, which is what we like. Okay, thank you all, and thank you ever so much for being part of this. We look forward to seeing you at future events. Thank you.